ladies and gentlemen, and welcome to the Women's Show, where we dissect different issues and different narratives within Uganda that speak to the women of Uganda. And today we have a topic that is not often discussed, but critical to women in Uganda, especially because a lot or the majority of women suffer from this ailment. In January, we celebrate the Cervical Cancer Awareness Month, and we want to give it a spotlight and a highlight within the work that we do so that you know or you have the information that you need to get checked or to even get help. And to help me have this conversation, I have a dynamic of women, some who are survivors, some who are in cancer institutes, but also some who have been caretakers of people that have suffered ovarian and cervical cancer. It's a conversation that is hard to have, but it's a conversation that we must have. And to help me have this conversation, I'm going to let you guys, ladies, to introduce yourselves. First of all, welcome to the show.
Thank you.
I'm really, really glad to have you in your different capacities. So you will introduce yourselves and then we dive into the conversation. I'll begin with you, Ritah.
Thank you very much, Tricia, for having me. My name is Ritah Kironde, and I am a legal clerk. And I happen to be a caretaker for a patient who recently had cervical and ovarian cancer.
You're welcome to the show.
Thank you, Tricia.
Thank you so much for the opportunity to be on this show. My name is Getrude Nakigudde. I'm a breast cancer survivor for 20 years. I'm a Chief Executive Officer of Uganda Women's Cancer Support Organization, an organization that takes care of cancer patients and survivors. And I sit on the board of directors of Uganda Cancer Institute.
Welcome to the show.
Glad to be here.
Yes.
Yes, my name is Akello. I'm a breast cancer survivor of 5 years, and I'm also a member of the Uganda Women's Cancer Support Organization. But basically, what I mainly do is I provide voluntary counseling for cancer patients.
And maybe to just start this conversation, I'm going to come back to Gertrude. And I am glad that you're on this panel particularly because from where you sit, there is a lot of information you have that some of us on a regular basis will not have access to. But to help us understand the narrative around cervical cancer, like what is it? Why is there like almost a blurriness on, having knowledge around it? We have knowledge around breast cancer, but what is it around cervical cancer that we need to take home with us today?
Thank you so much. Cervical cancer is one of the commonest cancers in Africa. And actually in Uganda, it's the most common.
Oh, yes, it is.
It's number one.
Yes.
If you put men and women together, and it's the major cause of death for women for cancer. And about 15% of all cancers in Uganda is cervical cancer. But what we need to take home, cervical cancer is preventable and cervical cancer is curable if caught early. But most of the people are not aware that you can even prevent cervical cancer. Cervical cancer is prevented through a vaccine, which is given to young girls who are not yet sexually active, but also to women who are sexually active. There's still an opportunity to be screened early enough. Because with cervical cancer, when it's early, there are no signs.
Oh, yeah.
So when you screened early, you can be treated successfully and survive.
Maybe to also make sense of it, because I think at some point we are all raising children. Yes, I'm a mother also in my own category. So we're all raising children. I want to bring this to you, Carl, because when you look at the level of sexually active narrative around young girls within Uganda, we have child brides, we have teenage pregnancies, and so it almost looks as though they're already sexually active before even they could get the chance to have the HPV, because the HPV rate is 8 to 12 and some countries to 14. But how do we then create sensitization around having parents take their children to get the HPV vaccine, or even get screening for the older ladies, so that there is seemingly work around prevention? of cervical cancer?
Okay, the thing that we have to come face to face is that generations have changed.
Oh yeah, that's true.
And children are getting exposed to things that they shouldn't know at a very early age. Sometimes parents even do not know that their children are sexually active. So it has to go back to talking to the children right from home. As a parent, you have to do sex education for the child and do not wait for the world to teach them.
Yeah.
When is a child supposed to start having sex? Can your children come to you to discuss that topic?
Yeah.
If somebody does something to them, are they free with you enough to come back and tell you that this happened to me? The other thing is cervical cancer. One thing people should know, it doesn't come because you are promiscuous.
Oh yeah, that's important to note.
Yes.
It happens to any woman who has ever had sex.
Oh wow.
Even if you did it once. It means if you've had unprotected sex, you have chances that you're exposed to HPV virus.
Yeah.
It doesn't mean you slept with very many men. Yes, that increases the risk, but any woman who has ever had sex can have it, even if you did it once.
Oh wow.
So the other thing is it takes time for it to grow into cancer.
Wow.
It could even take 10 years. You have the virus, your body is battling it, and then for some reason it has become chronic, and then it starts to develop into cancer. So the best thing we can recommend is routine checks.
Oh yeah. That's quite interesting. When you spoke about sex, and I'm bringing you in Ritah there, when she spoke about sex education, the first thing that came to my mind is one of the hardest conversations this country has failed to have is around sex. And I understand because that is how we were raised. It was a taboo conversation, but with the level of exposure that she talked about as well, how do we inculcate sex education within the curriculum and within the systems? Because the more we shun away from such conversations, the more trouble we are getting ourselves into. So how do we find ways of adding sex education to the conversations we have within our schools, but also at home?
First of all, as parents, we need to understand that this is a different generation and a different time altogether. The level of exposure is different from how we were raised.
Yeah.
So sex is not something that we should shy away from. It is something that we should talk about openly with our children. We should give them a chance to explore their sexuality, but in a supervised manner, you know? You're a girl. What is it about your body? How do you expect it to change? You're a boy. What goes on with your body? How does it change? When do you hit puberty? We should create an environment where our children are open, like they are open to talk to us about these conversations. When your child comes to you with a question that's it's very, very adult, don't come up with an excuse not to answer the question.
Yeah.
Find a way as a parent to answer the question. And even in schools, they teach about reproductive systems, but they just, beat around the bush. I feel like teachers should be very, very open. We have senior women teachers and counselors in schools. They should be able to introduce sex on a very public platform. What is it? Exactly. What
I
happens?
hear you there because, and statistically, so the level of influence teachers have on your child
is a lot.
Is more than a lot of influence that parents do have on their children.
And the chances are higher that your child will speak to the teacher before they actually confide in you as a parent. So our teachers should help us in a way that they should be able to talk about sex openly. Because it's not something to shy away from. We have social media, it's on the platform, it's everywhere, on the TVs, in the cartoons that our children are watching. Sex has become a topic that is as normal as having a meal, It's in everything that we do, from the way our kids dress to how we live our lives, even on the streets, to everything that we do. Everything is sexualized. So we should openly tell our children what sex is, what are the repercussions of having sex early, what happens when you delay, what is the overall importance of having sex, because sex was made for a reason. This is a godly, thing. What is it about? So you should teach your children on a godly manner what is sex all about. And then on a health manner, what is sex all about? Because we need to tell them how to have healthy sex. At what age? As a 4-year-old, watch the company that your kids are having. What are they doing? Pay attention to your children. Our parents have become very busy that they don't pay attention.
I hear you.
Pay attention. Because kids are growing up very fast. You find a 7-year-old who looks like a 13-year-old. Bursts, periods, menstruation. We used to have our periods at 14, 15. Nowadays at 6, a child is already. And as soon as a female, when you start growing into a female, your body starts to demand for certain things. So how do we teach our children to curb such demands? Because if we don't tell them, they're going to learn from other kids who are going to say, no, me, I did it like this. I'm doing it with this boy. I'm doing, be the lead person in your home. Tell your child. Back then, they would send you to your aunties. They'll send you. Now they don't. You, the mother, speak to your daughter. As a father, speak to your son. What is that thing meant for? How do you use it safely? How do you practice safe sex? And when they're ready or when they're not ready, it's also upon us as parents. Prepare your children for sex.
Yeah.
Yes.
Let me bring Nakigudde in. When you look at, I got the HPV vaccine and I was quite old, because I was a late bloomer. Like I was very green, and it was a saving grace.
Yeah.
But there was a drive, and because a lot of people say the HPV vaccine is very expensive, but the time I got the HPV vaccine, it was on a drive by government of Uganda, and it was readily available. And then people were doing screening, people were getting the vaccine for their children. I think I got it because also school-going children had now started to get it.
Yeah.
What I worry is, and this is where I noted, because we were giving the vaccine, then I was in healthcare, and we were giving the vaccine to high school-going children. But the only screening there was a question of, have you been sexually active? And so I worry because I don't know the effects of such a drug within the system of a child. Are there repercussions of taking the drug when you've been sexually active?
When they are vaccinating or when they are developing vaccines, most of the time they use the virus.
Yes.
So if they use the vaccine on you when you already have the virus, they're accelerating the virus. So that's why they insist that you are not sexually active. And if you are sexually active, you should be screened and proved out that you don't have the virus so that you're able to benefit from the vaccine.
And maybe also on that, can you do that screening through blood, or you have to do the pap smear?
Technology hasn't reached blood.
Oh, wow.
But it's pap smear, it's visual inspection, and there is a new technology where it's self-test. Kits are being developed in the world elsewhere, the developed world, so that you can do a self-test. You can do a swap yourself, and then like they do the HIV. So now you are not worried to go to a health worker to open up and then for your purposes of your privacy. But I'm sure very soon these kits will be here, because the issue of privacy is very important to them, especially when you're not in pain. Because we go to a health worker, either you're in pain and you want to deliver, so even if the health worker say open your legs, you will do comfortably because you want a baby out. But now that cervical cancer is not painful, and when you go for screening, I mean, the motivation to really be screened versus your privacy. So many people weigh that and they say, okay, I'll go when I have a sign.
I hear you.
And that is late.
And that is late because there are no signs. And that is what I was asking. And maybe you can also chip in when Akello is done. The fact that you can check yourself for breast cancer and know, this doesn't feel normal, I have a lump. And the juxtapose of that fact that cervical cancer, you can't do anything, you can't see anything in real time. What's the recommended times you can go for a check?
Okay, for people who are HIV positive, and maybe if you've suffered from any cancer, it's advised you do it every year.
Oh, wow.
once a year at least. And then for other ladies who are okay, no HIV, not going through cancer, but of course you're sexually active, it's once in every 3 years.
I didn't know that. Oh, yeah. So as long as you're sexually active, you have no other underlying problem, you've got to go every after 3 years. Does it help catch it in time? Because I wonder, if I went this year, and I know there are a lot of Ugandans in my corner, if I went after this 3-year bracket and there was nothing, the level of sustained, because we don't have the culture of health checkups, the level of sustained narrative around after 3 years I'll go back, a lot of people wouldn't. They're like, oh, I was okay the last time. Do people, and in sensitization, I think that is where we need help. Do people actually know that you need to sustain this checking?
As you mentioned, the sustainability of checking is very difficult. I think that's why we are always here to remind ourselves.
Every January.
Every January. That's why this month was really dedicated, so that we remind the ladies after all the fun you've had during Christmas and the holiday. Hey, remember, you may have had a lot of fun. Now your health first before you do anything. So we feel January is very important for all the ladies out there to ensure that you go do cervical screening, so that you, as you implement your year's plan, at least you know free of HPV. Yes.
And maybe just Ritah to come in there on a regular basis. Ugandans don't really. Everyone will tell you, and I am sorry to generalize because I need to cap, but I know for a fact, because I worked in healthcare, one of the hardest things to sell was general health checkup.
Sure.
It's like we would do all the checking. People will come and check for HIV, people will come and check for blood sugar. Nobody would spend time to say, okay, I have come to do a general health checkup to see how my body is functioning. And one thing I keep hearing people is, what if I go and give myself bad news? But the bad news we would always have found you anyway. So how do we encourage general health checkup? You know, the narrative of just taking care of yourself on an everyday basis.
Well, general health checkup, first of all, we need to look at, healthcare is a bit expensive, especially if you're going to do a general health checkup. I do not know if how affordable those services are in public hospitals, but I feel like you have to go to a private hospital. And for that checkup to actually happen, it's pretty expensive. So that rules out a category of people who can afford it. That I would have wanted to go, but I can't. I can't afford it. So maybe we should find a way of trying to make this affordable, first of all, to our general Ugandans, because we have a lot of people that cannot afford it. Now, those that can afford it have this stigma around it, that what if I go and I discover this? What if I go and, just like HIV. Oh, no, I can't go check for HIV. What if I find out? I'm doing okay. That stigma around finding out if you're okay. So we need to also sensitize people more that it is okay to find out if you're not okay, so you can seek treatment or help earlier. But can we find a way to make general, checkups affordable? Because quite frankly speaking, they're not.
Yeah, and I think maybe on that, I'll do a clarion call to our legislators to pass the public health insurance bill. Because I think for a very long time, we've left our health system to take care of itself. But I know for a fact that public health insurance will come in handy for people that can't afford everyday or private entities in regards to health care. The other question I wanted to ask, and rightly so because I don't know a lot about cervical cancer, but do infections, women go through a myriad of infections on an everyday basis. Once in a while, you have a clean slate of nothing. Then you use this one public toilet, and then you have a myriad of all these things happening. Do infections also heighten the exposure to HPV, or it's strictly sexual? And infections, candidiasis, UTIs, that myriad.
Yeah, continuous infections increase your risk. HPV virus is an infection that you can have for 5 to 10 years without causing cancer. Not everyone who has HPV has cervical cancer. So you can have HPV And if you're screened and the virus is found, you're treated and cured.
Oh, wow.
That's why they say you check in the span of 3 years. You can have HPV, but without
Any
cancer
consequences? Oh, yeah.
causing it cancer. But if you have continuous infections, especially HIV, that's why they say if you have your HIV
1 year.
positive, within
Check
one
in
year,
1
you have to
year.
check 1 year, because if you got HPV within 1 year and you have HIV, within 1 year, that virus may have turned your cervix into a cancerous cervix.
True.
Wow.
Because your immunity is so low.
Wow.
So if you also have exposure to other infections women always get, then your chances of developing cervical cancer are higher if you've got HIV.
Yeah.
Yeah, so it's always important that you screen, you stick to the routine.
Oh,
and you mentioned that the stigma of the news.
yes.
And of course, the stigma comes with the death.
Yes.
I think there is hope. As I mentioned, that when it's HPV as a virus, it's treated. You don't even need to go into the chemotherapy bit. They just freeze it for 6 weeks. You're done with HPV.
Oh, wow.
But when it turns into cervical cancer, that's when the story changes. But if you went early, you can survive. We have survivors. We don't have so many survivors of cervical cancer.
I noted.
Because many of us, as you mentioned, that you only wait to see, because the cervix is not like a breast that you touch it and feel it. But cervical cancer, you get it. You by the time you realize a sign, which is blood, which is painful sex, which is backache, those ones are too late.
Oh, wow.
It means it has eaten part of the body that are still sensitive to you.
Oh,
and
wow.
you can hear it.
So that is last stage.
That most of the time, it's
time.
last stage.
The critical question is, how do we know, even before we prevent, what is the recovery rate for women with cervical cancer?
Actually, survivability is really, really high because it's one of the easiest cancers to treat.
Oh, wow.
And it takes even a shorter time to treat cervical cancer compared to breast cancer. Because for them, mainly, if it's so early surgery, you could just do only a surgery and you're done. And sometimes you need the chemoradiation. And within a span of maximally 6 months, you're done with your treatment.
Wow, that's short.
And then for others, it depends on
the stage.
It depends on
so if it was early stage, it would be that it's possible I would survive.
Definitely.
Oh, wow. That's interesting.
It's more easier to survive it than breast cancer and other cancers.
It's interesting because of it's the most common, and yet it also has the most deaths. And that just a pox makes me worried, and yet it's survivable.
Yeah.
Most probably maybe because of the information, the level of information, and I don't know how different people are doing that. But maybe to talk of prevention, which other mechanisms can we do, not just on an individual basis, but on a collective, to prevent cervical cancer?
I think reaching out, I love the forum.
Yeah.
But also bringing out to the survivors to give people hope.
Oh, yeah.
Because when you hear, when you get cancer, the first thing you think about is death. So even people fear to go for screening because they'll tell you have cancer and you ultimately to be death. But if we increase awareness, integrate survivors, to give the stories, to give their testimonies, how easy it is to treat cervical cancer when it's early. Even those who have had pre-cancer, if you checked and you realize you had an HPV, and the HPV was treated within 6 weeks, you are back on the road. We should be able to bring out those to give hope to those who want to go for screening so that they can easily screen. Because the services are available.
Oh, yeah.
The services are free. All government hospitals, even NG hospitals, screen for free. And the corporate world, unlike other diseases, cervical screening is included in insurance. But corporate women don't even screen.
I know.
Because they know once you're told, then you're gone.
That is it.
So information is very key, but also using the hope stories, not the scary. We know cervical cancer, many people don't survive for 5 years. About 18% of women survive within 5. If you had 100 women who are treated today, in 5 years, you only find 18.
Oh, wow.
But for breast cancer, you'll find about 56.
Yes.
Yes, so that's how low it is. But it's preventable and it's curable.
And maybe also on that, I was reading around it and I actually realized the government is doing quite some work around, raising awareness around the mobile clinics that we were talking about earlier on. And seemingly there is work being done. I wonder and then I don't know how self-aware a lot of people are. I wonder if the level of awareness around cervical cancer is grand, because a lot of people know about breast cancer, and rightly so, because we spend time talking about it, having this conversation. But why is there sort of a cloud around understanding cervical cancer? And then maybe also after that we'll have a conversation around caretaking and taking care of a person that has cervical cancer. But help us understand, how do we not just remove the cloud, but remove the privacy around understanding cervical cancer?
Okay, first and foremost, there is stigma around cancer, yes, but also the misconception about how cervical cancer is got. People assume because you have cervical cancer, you're promiscuous. It scares a lot of women from coming out and saying, I was treated for cervical cancer.
I hear you.
Or I was treated for HPV. Or even go for a test. It's like I'm telling people, you people, I'm promiscuous, see me, I'm here. So there is that challenge.
It makes sense now.
So people need to understand that it's not about how my sexual lifestyle is.
It can happen to any woman.
It can happen to any woman, as long as you have ever had unprotected sex. It can be once. So there is that big challenge, and that's why you see someone gets treated, they are cured, yes, but coming out the way breast cancer patients come out, no.
Okay,
there is that big
makes sense.
problem.
That makes sense, because you never understand. Because I don't see a lot of cervical cancer survivors,
And they are there.
and they are there.
Yeah.
But let's talk about caretaking. I know that you've experienced taking care of a person who had ovarian and cervical cancer, and a lot of the conversation that we have on a daily basis on a lot of these caretaking systems is that there is help for the patient,
True.
but there is rarely help, especially psychosocial support for the caretakers. So what needs to be done?
First of all, taking care of a patient, any patient, is hard. It has its challenges. But for cervical and ovarian cancer, what makes it very hard is that a person is in so much pain and you don't even know what to do to help them. Like, you watch a person cry like a baby. The pain is too much, it's unbearable, and you don't know what to do. That affects a caretaker psychologically. It also depends on the relationship you have with someone. In my case, it was my mom, So it becomes that, of course, the medicines are so many, and there are very many complications. There are very many things that come with having cancer. For my case, my mom had clots, which made it very hard to do a surgery to remove her uterus. In as much as we would have helped, there was no way
to help.
Because she has that bilateral, it has both legs. So it's very many things that happen in there. You as a caretaker, the medications are so many, the sleepless nights are because they don't sleep. They tell you the morphine works, but it works and then it stops working.
At some point.
That is the honest truth. They give it to you orally, they give you injectables, they give you drips, but at some point, the cancer pain surpasses the morphine, and it can't work. And then you don't know what to do for a person. You do the very same things every day. You clean them, you make sure they take their medication, but it's not helping. And then you watch a person deteriorate slowly by slowly every single day until they die. because it is stage 4. For my case, they can't operate because they are clots.
Quite late, right?
Yeah.
Yeah. Okay.
Because if they operate, she will bleed to death. You know? So you as a caretaker, you're taking care of a person, but you know they're going to die.
Yeah.
And there is nothing
It's just a matter of when.
Yes, there is nothing you or the doctors can do about it. You will fight and fight, but it will happen. You're just delaying the inevitable, you know? So you sit there to just make a person comfortable. That's it.
You're just giving palliative care.
Exactly.
Help me understand psychosocial support post-care of a cancer patient. Because even for survivors, I know that the caretakers, most probably in their sigh of relief, needed help.
Yeah.
Are there services to support caretakers post-care?
As an organization, we support the patient, but also we support the caretaker. We counsel them, we provide counseling, and we guide them on how to deal with the whole. Because as a caretaker, it's more distressing than even the patient.
Yes.
As a patient, you accept and you say, I will fight. I've been a patient, but I've also been a caretaker. My father had breast cancer also. So my father had stage 4. It was more painful to take care of him than myself. Because now, as she mentioned, you watch this person in agony. I mean, the pain, even if you gave morphine, this person cannot sleep, this person cannot, and then you get more pain than even the patient. So the psychosocial support needs to be, as an organization, we are not well equipped enough in terms of staffing, in terms of resources, because you need to talk to them, you need to visit them, you need to comfort them, but we can't reach everyone. But that's our core business, supporting and then counseling. But it's very, very important that we need to mechanisms of how to support the caretakers.
But also on the part of how to help caretakers, the one thing that I read from one of the I think you know the cancer information for caregivers. There was a part where I read and it says one person should not be the one left to a patient for a long period of time. You need to take time off.
Have a routine.
At least let another person come in, go take a break. Even if it's like for 2 weeks, a month, let someone else come in. So if you are family of many children or other relatives, at least like take turns. Do not leave this person to one individual. It's so draining, physically, emotionally, and the one giving care can even end up dying before the patient themselves.
Oh wow.
Yeah, very true.
Yeah, for me, my daughter was with me from the point of diagnosis through treatment, and by the year 2020, I could tell this girl needs a break.
A break.
She was emotionally withdrawn. She was no longer a child.
She's an adult.
So when time for school came, by the time she was in day school, I said, no, let her go to boarding school and be a child. And trust me, it helped. She came back a happy child.
Oh, wow.
Yeah. So having to be there all the time and every day, every second, this person is crying in the night, you're listening, that distress is worse than being sick. So please, if you can, give them the break. If you are a friend and your friend has a patient, please, if you can, even if it's just for a few hours, go sit there, let them take time off. Just go take a walk, go out there, think about yourself for some time.
Be a child. Live for a moment.
And
because it mentally drains you.
It does.
I have taken equally care of a breast cancer patient, but many years later, because it's been very many years since they died, but I remember the agony of going through Cancer Institute, going through radiation, turning into second line chemo. I remember it even today. The difference is, as the years go by, you start to tell yourself, there was little you could do to help.
Yeah.
But the mental toil that you have is something that needs maybe counseling or therapy to help you, you know, not forget but accept or deal with the realities of what you went through. And I think that's a conversation we miss in treating cancer patients. But let's go back to the facts, because I need the facts so that when I leave this place, I know what to do. I'm an adult of sound mind, and I'm taking this to Nakigudde. I'm an adult of sound mind. I am sexually active. I'm a female in Uganda, and I know that I am supposed to be able to go and have. How do I, like, even with the screening? What other things should I do? Should I be looking out for signs? Should I be maybe reducing my body count? What other things should I be doing to prevent me getting cervical cancer?
I think now that we know cervical cancer is a virus which is sexually transmitted, I think as an adult, if you're married, you have to be faithful.
Oh, yeah.
And if you are not yet married and you don't have a permanent spouse, a permanent partner, you have to exercise care as much as possible. It also says that even a condom is not safe enough.
Oh, yeah.
So don't say I'll use a condom, because cervical cancer, HPV virus is through fluids, not blood. So the issue of blood, it's more protective when you wear a condom. So even if you are wearing a condom, you should be cautious. But most important, screen.
Oh, yeah.
Screen, because when they find that you have HPV virus, the virus is treatable. It doesn't mean you have cervical cancer. We mentioned that you can have the virus for 10 years, but when you're free from cervical cancer. So screening is the key. If you're still, as you said, you are above 20, but you hadn't engaged into the so you had the vaccine. So those who have an opportunity to get the HPV, it protects you, not 100%, but a bigger percentage, a good percentage be protected, and protects you from other infections. Because now the conversation is going to talk about, of late, sex has changed. There's a lot of oral sex. As we talk about cervical cancer, we should be able to talk about oral cancers, which is also increasing. Cancer of the tongue, esophagus cancer. So all those are caused by HPV virus.
Tell me about it.
Anal cancers. Anal cancers.
Wow.
Yes.
Is also
HPV still?
HPV still.
It's actually the thing
I'm now
about
shaking.
the thing about HPV is any part of your body that is exposed to it, and then it becomes chronic in that area, it means cancer can develop there. So if you were exposed to the mouth,
Cancer.
it
Tongue.
can throat, very high possibility. If it goes to your stomach,
Wow.
mm-hmm,
So it's not just, HPV doesn't affect just the cervical area of your body.
It can even be the
Any
vagina.
part where the fluid. Wow.
It can be the penis.
Wow. Okay. I have so many wow moments because it's overwhelming to take in this information at the same time, because it's the imagination that HPV and cervical cancer are just the only thing. But to realize that your whole system can actually be.
Where the HPV virus is put is where it develops.
Oh, wow.
So I know we are in a generation of millennials, but we also need to tell our millennials that there is a hard reality. Much as you're saying you're being up to date with sex and you want to do what everyone else is doing, there are very serious consequences. And as much as abstinence is not something that is cool nowadays,
cool thing now.
It's actually very, very beneficial. And because it's the only way you're going to delay your chances of being exposed to this virus. And it means it makes it possible for you to live your life without suffering from these cancers. But unfortunately, our young generation thinks the way to go is have sex anytime, anywhere, with anybody. and yet in actual sense, you're exposing yourself. And many times people think it's the men that are spreading it. But if a man sleeps with a woman who has it, he can get it also from the woman. So it is either way.
Yeah.
Who has it? The one who has can spread to the other
Spread.
Yeah.
Interesting.
And we can also prevent it through our feeding. Build your immunity. Because our bodies are designed by God in a way that it can fight off this virus.
Yeah.
But also, you remember, we are in a generation where people are feeding more on junk than
Than
the more
organic
healthy
food.
food.
I hear you.
Feeding on junk is feeding rich.
I hear you.
And then the food that really supports the body to fight all these illnesses has been taken as food for the poor. So the fruits, the vegetables, that mukene that you're bypassing on that and going for KFC could have helped you
be the one to
prevent
help you.
a bigger problem in the future.
Oh wow. I hear you.
So yeah, we go back to the basics.
Eat healthy.
It's
It's also important.
It's very important.
I'm here and my head something is scratching, but before we go there, I'm coming back. Because how do you now think it's screen for the throat? But let me come back before that. Healthcare and the expense it takes, because you know the bills, you saw the bills. How do we make, and I know we've had this conversation with you, Akello, but I still believe cancer medicine is expensive. Taking care of cancer patients can dry your pocket.
True.
So how do we find, and maybe this is where your information with the organization will come in handy. How did you manage bills? But then also, how do we find a subsidy? So we'll just have that conversation on bills and expenses, and then go in how we can help the patients.
Okay.
First of all, a medical bill is a medical bill. I don't think there's a subsidiary or cancer medicine is expensive.
True.
Yeah.
Cancer is an expensive disease.
Yeah. It is.
It is. The most unfortunate bit is that it does not pick who's rich, who's poor. When you visit the Cancer Institute, you can cry.
There's no class.
Cancer knows no class. And the medicine is the same. And if you can't afford it, quite frankly speaking, you will die. There is no other way. There is no primary, there is no option. If you're doing chemo, you have to do the chemo. If you're on injectables, you have to be on injectables. The tests are expensive. Those pap smears, I'm telling you, we were discussing earlier when she said that cervical cancer is not private. When you're sick, the times they have to, Lord, and you as a caretaker, if you have to watch it, it's disturbing. It's very, very disturbing. So the bills, insurance, I don't know, people need to, medical insurance is very important.
Yeah,
people look at it as as an expensive thing that you're doing, but when you're sick and insurance can help you, you do not know how much of a miracle that can come in handy.
Getrude said it is actually covered under insurance.
Yes.
And people don't use that.
Cancer should be something that it should be covered. Because if you have health insurance, it can help you a lot. Because if you do not have money, serious money, you will watch your patient die. The medicines are expensive. There is nothing cheap about cancer. Even these simple orals that you have to take, they're expensive. So we need to encourage people to actually do health insurance. It's important. Because it's a little inconveniencing and expensive right now when you're paying for your insurance. But when you have cancer and the insurance is coming in,
I think even any disease at this point,
the
insurance will come in handy.
Yes, it will come in handy. So we need to advise people to, if you can afford health insurance, please
Invest in it.
have health insurance. There are people who work for companies that are lucky enough to provide for these kinds of health insurances. But if they don't, please work with your families, because
you can
they
actually
help.
have an individual family plan on your own.
On your own, yes.
And you try to service it and keep it active.
Because if you want to fight for your patient, if you want to fight for your family member or whoever person you're taking care of, you've survived breast cancer, you've survived all types of cancer, you know that you need help. Financially, you do. Because these bills have to be paid. there is no other way around it. And with doctors or hospitals, you cannot select them. They don't do let street we shall pay. It's a pay as you go system.
And I think the challenge is also cancer, because there was a time HIV was where cancer is right now. Like you would shudder to know that there is someone dying of HIV, and today you shudder. Let me tell you, when I hear someone say I have breast cancer and I survived, that is a hero to me in my face, because there is this misconception around cancer that it's almost like a death sentence. And so I understand, the fear in not paying those bills because you're so sure you're failing your patient. But how do we help? How do we subsidize? And I'm hoping that there are ways to help, especially financially.
Yes, thank you so much. As she mentioned, actually, globally, there is a new term, financial toxicity.
Okay.
So when they were developing medicines, they were like, when they give you this medicine, it takes your hair off, it makes you this. But we have been forgetting the financial toxicity is higher than any toxicity you would get in cancer treatment. Because what we see in Cancer Institute, the government pays. Otherwise, if they don't pay and they tell you buy those drugs, nobody would afford it.
Very true.
So that's why you were saying, why don't they vaccinate all the children from year 1 to 13?
That is what I was saying.
So, but even the cost of the vaccine is so high for a government to. That's why they look at the most beneficial age, and they say maybe 9 to 14. Those are maybe 90% of them are not active, and then they take a risk and they vaccinate those. Otherwise, they would have vaccinated everyone, and in other countries, even they vaccinated the boys.
True.
Interesting.
Yes. But here, because we can't afford, we say, okay, let's
be helpful. Also.
Yes. Let's protect one part. Probably others will also be protected to a certain level. But it should be for everyone. But because of the cost,
I actually didn't know that even boys can get it.
Because of we adopted the oral, the anal, the esophagus. So where you put the virus is where the cancer. And this is an interaction between a boy and a girl, or a man and a woman. So either of them, but who has the highest risk?
A woman.
A woman. So that's why the vaccine goes to the woman. Going back to the bills, one of the measures the government is providing a bigger percentage of the drugs. Because as an institution, like as an organization, we can't afford. But I think we have to just join hands and advocate for a budget increment. And probably also engage the insurance companies to ensure cancer. Because insurance covers the screening,
but not the treatment.
Not the treatment. Because it's expensive. If you are to use your insurance package, most of the people who have insurance, they stop on surgery. Then they say your insurance is completed.
So the radiation,
the
surgery treatment.
And also you mentioned that during HIV it was like that. Cancer is a unique disease. Actually, cancer is a number of diseases. It has this, the family. So even the checkups alone to establish the type of cancer is also another cost.
Yes.
Because with HIV, you check blood and they say I'm positive, then you can start on the treatment. But with the cancer, they will get the sample maybe by surgery, check it, which type, which stage. So, or even to establish a stage, what you need is also a cost, which is expensive. Then the treatment that you need, cancer is treated by a combination of drugs, never one drug. About 6 drugs. A cocktail. So in that cocktail, government may provide 5 of them. Then you have to buy
the one,
or the other. Because we can't have that supply to 100%. So as a family, then it's very, very challenging. So I think the most important is prevention and early detection. Because when cancer is stage 4, you're treating the initial site of cancer. If it was cervix, if it is stage 4, it has gone to the kidneys, it has gone to the bones,
it has spread everywhere.
It has got to, so you have to treat the kidney, you have to treat the stomach, so you are treating all the, and each part is treated different. So that's why you need a cocktail of this, a cocktail of that. So even the government can't afford. That's why at the end of the day, as a patient and a family, you are always coughing money. Because they may have this cocktail for your cervix, but they don't have that cocktail for the liver. So they say, okay, buy this. So it's really important that we treat the disease in its earliest stage. I'm surviving because I had stage 1 breast cancer. Even breast cancer is complex. It goes to the lungs, it goes to the stomach, it goes to the bones, and each one treated differently and over time.
That's interesting. You still have one question for me that I paused on. If HPV is in the throat,
Yes.
how do they check it?
Screening has not been developed most of the body parts. For example, the throat is very difficult.
Yes.
Now that's why we say women screen, because there are standards that are put in place, like screening the cervix. They are certain, because they have to go through trials to see whether it works or not. So there are certain things that certain cancers that can be easily screened, and others may not be. The throat, the stomach, these machines,
the endoscope.
But those ones test the rare disease that is already there.
Oh wow!
So the earlier you prevent yourself from the HPV, the original HPV screen, because the biggest site that collects HPV is the cervix. These ones come as
by the way.
But where you have an opportunity to visit your health worker, you visit and they can advise you accordingly.
Oh, that's interesting.
Yeah, so I wanted to comment on the part of the treatment that Getrude talked about. Okay, currently, Uganda Cancer Institute has been named as the Center of Excellence for East Africa. One of the main reasons is because they have most of the medicine. You come to Cancer Institute, you can get most of the treatment there. Yeah, so it's possible to come to Cancer Institute and try your best to make sure that you pay as minimum as possible. And that's when you go for general treatment. But even if you went for private treatment at the Uganda Cancer Institute, it's subsidized because you're paying for maybe a consultation, a nurse's fee, and maybe blood tests only. And yet, those blood tests, if you do them outside, you may pay like 35,000 or 40. Here, they will charge you 10,000.
Wow.
If you are going to do a CT scan, if you went outside, maybe they're going to charge you 350 or 400,000. Here they may tell you pay 300,000, or I mean, let's say 200,000, 150,000. So it's not much, but there is a difference. It helps.
It's a saving.
Yeah.
And then most of the chemotherapy is available.
Yes.
And for me, I have benefited from it a lot. I last paid for chemotherapy in 2019.
Wow.
And I
That's
paid.
A while.
Yes. So of late, most of the drugs are there. When it comes to cancer medicine, they make sure that at least they have most of the medication. Patients don't have to buy. Or even if they're going to, even if it's out of stock, within 2-3 days it's in. So a patient can get their treatment. But the biggest challenge we are also having is people who want to go get treatment abroad.
Oh, yeah.
I have no problem. If you have your money, go get your treatment abroad. And Getrude, I'm bringing this up because there is a misconception that at the Cancer Institute, cancer can't be treated.
Because
it's
I keep
a very
seeing
big
drives.
misconception.
The drive for
very,
this,
very
a
big
drive for
misconception.
this.
That's not right. And actually, in most cases, people go out, get stranded, or end up
and return,
or end up in wrong hands. Because there are also cartels of Indians or Chinese who are like, let's get us some patients. You get a cut from this money they pay for the treatment. And to make it worse, you're going to get low-grade medicine compared to what is available at the Cancer Institute. And then, cancer is not an illness that you treat within a month.
Yes.
It takes a while. So are you really sure you have the sustainability to stay in India for 8 months? Are you sure that after those 8 months you can keep flying back to India to consult
you began
to
getting from
consult your oncologist?
Mm.
Because tell me, trust me, even Getrude still goes back to her oncologist.
Yeah.
20 years later. Are you able to afford to keep going back? You have a
for a
complication.
20-year
Yes.
period.
Or now just imagine, like
Wow.
for me, I treated breast cancer. They ended up finding out it was in the spine. Later on,
You treat
the
that
lungs. So are you going to be able to sustain that cost?
I hear you.
So people need to be told the truth. Cancer is not a lifestyle. It's not a disease that you're going to say, me, I want certain
I want
class.
this.
Yeah.
You get lifestyle care. You need to use what you have, especially because it's available.
It takes long and it's going to drain you.
Sure.
That money you think you have, it can disappear and you're like, what happened?
But I know there are people who actually don't know that there are subsidized services at the Cancer Institute.
Yes.
Because people end up in private care, people end up in different entities. But the knowledge to know that if I went to Uganda Cancer Institute, I would get enough help comes much later on when it came much later on for us when we were treating our breast cancer patient.
Yeah.
When we had already spent the majority of the money in private entities. So by the time we went, we were actually, the medical statement from it was like, this is last stage carcinoma. That the most we can do is provide palliative care. And maybe also that's a conversation I want us to go into. At what point do health systems, decide that and I've never had anyone say it, we just deducted that now we're on palliative care. But they never tell you. At what point do health ethically, I don't know if they're bound to say that now your patient, you need to go home, put your estate together, and you're now on palliative care. Do we come to that point in time?
I think the conversation lately, treatment, they follow guidelines.
Oh, yeah.
But there has been a big revision on treatment guidelines. Lately, palliative care starts from the time of diagnosis.
Oh.
Palliative care doesn't mean end of life care.
True.
But it's a component. Because palliative care has the physical, psychological,
Yes.
emotional, financial. So the patient should be supported as and when you move from one stage to the other. So end of life care should be the last, but should be integrated early enough, not to shock you to say now we can't do anything, now go. Because it involves counseling, which has not been there before. Doctors would focus on the disease, but when it doesn't go, they say, look for a counselor. But now we are advocating that from the time they give you the news, whether the disease is stage 1 or 2 or 3 or 4,
palliative care
somebody
begins.
should come in to give you information, counsel you, give you hope. Then prepare you that if there are any pains, that is a physical, do you have wounds, then it should be treated like this and this, so that they don't wait for you to suffer the pain and they say, oh, there is much in there, I think you should. That's what happened to my father. My father was stage 4 at diagnosis. But we were there, even me, I was stuck because we want to do everything. But then later, at home, I realized was in too much pain. I said, but there is much in there. Then I had to call because I knew somebody from hospice. And this man had not slept for a week. He was wailing like a baby. Wow. Like a baby, he couldn't even sleep. He could be like this. But then we realized this thing should have come far much earlier. So there's no time that palliative care should start here. Palliative care should start from the word go, with information. What is available? What do you need to know? The issue of the rotation of caretakers, the financial planning. You need to plan it because, as you mentioned, you started from a private hospital, took all your money, and they are not doing anything. So the financial planning should also come in. Your patient is stage 4, but you can live 5 years. Plan this way. This is what you'll need. The treatment will be ongoing for the next 5 years, not one day, not one. So that you plan your resources well. You need your teams to plan so that if you are not there, somebody else should be able
Someone
to
is
come,
available to help.
support. Yes. Yeah.
Well, that's interesting.
But
Ritah?
also as a caretaker, if you're very insisting, for my case, when things got so bad with my mom, the doctors actually told me.
Oh, wow, that's interesting.
Yes, he talked to me and he said, you know what? You need to get your mom's affairs in order. Because now her liver was, her lungs were shutting down, her liver was, everything was, and I could tell. And he was like, your mom is going to go into cardiac arrest, and when that happens, I don't know if we can get her back. But at some point, I feel like the medical personnel...
Did that come early on, or
no,
as the treatment was going
after
on?
I had, how you do everything.
Yeah.
Yes.
And they ask you for everything. And then there's nothing they can ask of you, like she was saying.
Yes.
And then that's when they remember to prepare you
Yeah.
for what is happening.
Yeah.
In as much as psychologically, as a caretaker, when you watch someone, you know.
You can.
At the back of your mind, you're treating a person, but you know.
But you lucky keep hope.
But you lucky keep hope and you keep fighting. Because you keep fighting until they draw their last breath. Now, the medical personnel should be able to prepare you. It's important. You can be with someone in the hospital for 6 months, 8 months, but believe me, when a person dies, it's like you didn't know it was happening.
Exactly.
Like, even when you knew it was happening, but if you're prepared, there's a little bit of consolation that comes with it.
Yeah.
Because these medical personnel know how to handle you on a mental level. It's not a physical, it's here. They tell you what is happening, they tell you how it's going to happen, they tell you what you should do. Because for me, the medical doctor pulled me aside and said, you know what? This and this and this and this is happening. And in approximately 4 days, this will happen.
Prepare yourself.
There's nothing we can do.
Wow.
But it should come earlier.
It should come earlier, because I'm imagining you've gone through this whole emotional turmoil.
Yes.
You're exhausted on a physical and mental. So to take in this information should have been something that you prepared yourself for. It's like, oh, this is the time that they spoke about.
Most especially for patients that are confusing. Because you can treat a patient and feel like they're getting better, Then you get some little bit of hope, right? And then 2-3 days later, you go back to zero, So for patients like that, I feel like medical personnel, because for them, they know. If you're treating a person who has cancer now, and then they develop something like a foreign body outside, and then they drain it. For my mom, they kind of had to do some draining the abscess because it was like on her uterus. You feel like she's getting better. The doctors are like, oh, okay, she will get better. 2-3 days later, she's not getting better.
Yeah, so on that, I remember I talked to a doctor. When I did my CT scans, and I was told you have a fluid in your lungs, you have tumors in the lungs, and so I asked my doctor, so what now? And they told me you have more chemotherapy and what. So I asked, what is the purpose of my treatment?
Sure.
Is it cure? Is it pain management? What are we doing? And
That information is important.
Yeah. So actually, she told me every doctor is supposed to tell their patient the purpose of the treatment.
Oh, wow.
So if you're in stage 1, stage 1 and 2, the purpose should be cure. Stage 3, there is still hope for cure. Stage 4,
it's pain management.
It's more of
prolonged life.
Prolonging life.
So, no one gives you that. Okay, I didn't know that information because most probably it's not something I've ever asked as well.
But it's supposed to be the duty of the doctor
to let
you know that the purpose of treatment is prolonged life. So you go for this treatment knowing this, I'm on it to buy time. I'm on it to get cured. So, and there is a possibility that as you buy time, your body can surprise and get cured.
Wow.
Yes. So it goes back to, like she says, the patient was getting better in 3 days, and then after that, you go back to zero. I'm very sure those doctors knew that it wasn't for cure, it wasn't for prolonged life, it was
pain
just
management.
pain management. But they did not inform her. So that draining of the abscess
Of course, you know, abscess, that
Yeah, yeah, yeah.
pass
There's a way it
causes you
makes
to
the
have a
body
lot
to
of
pain.
pain. And when
Yeah.
you're in too much pain, your distress is so much that everyone can tell you're so sick. But then if it's drained,
You feel a
you
little
get
bit
some
better.
relief.
Oh.
So they are managing the pain. It's just that they are not informing you that we're doing this to manage
The
pain.
pain.
Yeah.
That's interesting. We talked about something earlier, and I think it's good information to have because government has community-based screening, mobile clinics, and they're doing the work. But which more support can be there? Because on a rural basis, and I think that's also a conversation we had previously, in rural centers, you know, the access to cancer medication and cancer care is not as prevalent. You need to either move yourself or be really keen or have your ears on the ground to know, screenings are going on here, or there is a mobile clinic happening. How do we have a better cancer support system for Ugandans to be able to, you know, have access to care and access to medication on time or in a seemingly good period of time?
Okay, Gertrude will help me out on this, but what I can first and foremost say is, I know that Uganda as a country does not have a national cancer control plan as yet, although it's underway and it's in its final stages. But of course, that would help because with that control plan, you have chances of getting bigger partners coming because you know even the financial aspect is involved. So because I want to do outreaches, yes, but then I need some money to reach those people out there. So I can get more partners supporting me if I have a plan in place. And it should be a national plan. So they come in and say, yes, we can work with this plan. We can come in this area. So that one, if it's effected as soon as possible, it is going to help us.
Oh, yeah.
And then, of course, we know that we are getting to have regional centers. There is Gulu, Mbale, Mbarara is actually operational. Gulu, at least Lacho Hospital is operating, and then even Gulu Hospital has a section somewhere. Arua also, the Arua Hospital is giving basics, maybe the screening and what, and then referrals are made. But also we have to look at the fact that as a country, and when it comes to medical, for you to treat cancer, you have to be an oncologist. To be an oncologist, you have to specialize in oncology, and that takes time. It takes finances. Not everybody can afford. That's why we have when it comes to staffing,
There are few.
So even if we opened this center, so it's going to work in them.
These centers.
So in as much as we want to dive into all this, we also have to think of we are also training the workers. So as Cancer Institute, I know they are doing what they can. As a country, they are doing what they can to maybe get some scholarships for people who are willing
to do oncology as a specialist.
And remember, there's a radiology also involved. Not everybody can operate a CT scan. Not everybody can operate a radiotherapy machine, and all those complexities.
So we need more radiologists and more oncologists.
Yes.
At least to beef up manpower.
But when these regional centers begin to operate,
we have
people to be there to treat the patients. So all these dynamics come into play. But as Uganda, I can say we are doing something.
Oh yeah. Gertrude, on that note.
Yeah, in terms of screening, there have been a training of all health workers in all regional hospitals. Actually, at up to district level, all midwives have been trained how to screen at least cervix and then the breast. So if we went to a hospital in a district, at least a nurse should be able to screen your cervix, especially when a woman goes for family planning and they are providing this. Some of them don't because of resources, but at least the knowledge is there.
It's there.
Yes. So in terms of treatment, the Cancer Institute has regional centers. We have Mbarara, which is now up and running. Gulu, the center is being in the final stages. The buildings are being set up, put up, and anytime we shall be commissioning it in this financial year. Arua, within the Arua Regional Referral Hospital, its services are there. Palliative care is there, screening is there. Mbale has not started, but Mbale has a hospital, can do some of the work and do referrals. Yes.
Where do we go from here, ladies? And in 1 or 2 minutes, what's the conversation after this? How do we not just evangelize, but increase awareness? And in one minute, we'll go. Where do we go from here?
I feel like women, mostly women, should understand that it is okay to go and get checked. There is nothing shaming about it. There is nothing embarrassing about it. You are protecting your life. Because late detection is expensive and it's a death row. So be okay with being checked.
Oh, yeah.
Just be okay with it. Yes.
Akello. And I want to know if you guys had a drive, like the way we had the drive for breast cancer, was there a drive for cervical cancer as well? But I'll get to you before that.
Okay. Okay, for me, what I can say as a country, as Ugandans, first and foremost, we have to take responsibility for our actions.
Yes.
Our sexual behavior, our lifestyle, whether feeding and whatsoever. We have to take responsibility. And then please, let's stop stigmatizing. Please, there is no shame in being, nobody wants to be sick. If it happens to me, it doesn't mean it cannot happen to your wife. It cannot happen to your sister, your mom, your cousin, or whoever. So please, let's not look at these people like they are the sinners. Let's give them that platform to be comfortable to look for help. And it begins from each and every one of us. And as I said last time we were here, today I have information about it. You have information about it. Tell a friend, and a friend will tell another friend. Before we wait for the government to come in to do this thing for us, the health is ours. It's me who is sick. It's my relative. It's your relative. It's yourself. So let's be the ones to start. And then the government will find us on our way.
That's important. Getrude.
I think each one of us should be an ambassador. The responsibility begins from me, but what is my responsibility to screen? There are resources, there are services that are available in our midst. And I really emphasize the corporate women. It's so disappointing that you see somebody working in the bank, somebody working in the high court, coming with advanced disease. We know there is stigma, but at least for us we have the access. At least let's do screening. Early detection saves life, but also share information. But also we are an organization of women who have survived. We reach those whom we can, we support, we counsel, and let people make use of our services. They can reach us on our social media handles. They can visit our offices in Kamocha and be able to share the information that we have. And also maybe invite us more on these forums. We want to engage in these conversations and reach as many Ugandans as possible. We are an organization of survivors of over 200 women who have survived the cancer.
That's a good number.
But we want to beat this stigma so that all these women can come out and say, yes, I beat this cancer. I'm here to support others.
And like I always say, you guys are my heroes because you bring hope to a seemingly hopeless thing. So you build our hope. Every time I see you guys, I tell myself, this can be fought. This can be won. And maybe on that note, I want to thank you, ladies, for joining us on this episode. For the brevity in sharing, but also for the information that you carry that is important for all Ugandans. If you're there this Valentine's, as it comes in February there, get your girlfriends. Go, check, screen, and, have a party on making sure that you're staying healthy. Also, touch yourself once in a while to find out if you're okay in your breast. But screen and screen and screen for cervical cancer. You never know what you'll find. You may save yourself at the end of the day. Thank you for joining us for this episode of The Women's Show. I was your host, Tricia, Gloria, Nabaye. See you in the next one.